The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello, and welcome to our broadcast, Improving Recognition and Management of EGPA, Multidisciplinary Approach to Individualizing Treatment. My name is Dr. Michael Wexler, and joining me today is Eric Capood. All right, let's get started today, and let's review, first of all, our agenda. First of all, we have got two master classes. The first involves recognizing and diagnosing EGPA and what are the challenges. And the second involves individualizing treatment for patients with EGPA, exploring novel treatment options. After these presentations, we'll discuss a patient case that will offer practical strategies for the diagnosis and management of EGPA within the context of a multidisciplinary approach. There will also be an opportunity to ask questions of the faculty after each presentation. Lastly, please be prepared to answer follow-up questions throughout the program after the scientific sessions. Let's start off by my introducing Eric Capood, who's going to discuss recognizing and diagnosing EGPA. What are the challenges? Eric?
Thank you, Mike. Everyone, thank you very much for joining us today and taking the time to learn a little bit more about what is EGPA. The earliest description of this disease was made by two American pathologists working at Mount Sinai in New York in 1951. Jacob Scherg and Lodi Strauss submitted a case series to the American Journal of Pathology, in which they described 13 patients who all had a clinical triad of asthma, peripheral blood eosinophilia, and vasculitis. Biopsy specimens from these patients were significant for the presence of a histopathologic triad 2 of extravascular granuloma, eosinophil predominant tissue infiltrates, and necrotizing vasculitis. Scherg and Strauss originally labeled this disease as allergic granulomatosis and meningitis to reflect on the one hand the clinical features of eosinophilia and asthma, and the presence on the other hand on the histopathology of the granulomas together with primarily small vessel vasculitis. The syndrome was also subsequently eponymously referred to for many years as Scherg-Strauss syndrome. Contemporaneously, though, as part of the general trend in rheumatology to move away from eponymous nomenclature, we refer to this disease now as eosinophilic granulomatosis with polyangiitis, or EGPA. EGPA is an eosinophilic systemic disorder that can affect a wide variety of target organs. When we think about EGPA, we are thinking of a patient with moderate to severe asthma and peripheral eosinophilia together with systemic features. The most common of these features are a mononeuropathy or polyneuropathy that can be motor predominant, but is also sometimes sensory predominant or can present with a mixed picture of motor and sensory, pulmonary infiltrates, and sinus disease. From a pathologic standpoint, we think of patients with biopsy evidence of tissue eosinophilia and or eosinophilic vasculitis. There is also the presence of ANCA autoantibodies in a large number of cases. One very important point, though, that I want to introduce here, and which we will come back to repeatedly in today's class, is that while a subset of EGPA cases are associated with the presence of an ANCA autoantibody, and this autoantibody has some specificity, its presence or absence is not absolutely required to make a diagnosis. ANCA is actually detected in less than half of cases, as you see here, and some experts continue to debate if ANCA positivity defines two different disease subsets or if these are in fact two different diseases with overlapping features. Regardless, the point about ANCA and EGPA is that its presence has prognostic implications and is associated with the risk specifically for vasculitic end organ features, which we will come back to in more detail in a few minutes. A key challenge with diagnosing EGPA, though, is that beyond the acquired asthma and peripheral eosinophilia that have to be present by definition, there is significant heterogeneity in the systemic features which one can see. Pulmonary involvement is almost universally present. Asthma, typically refractory again, is present by definition. Fleeting and patchy pulmonary infiltrates and alveolar hemorrhage are also often seen. ENT involvement is common too at diagnosis and is present in about half of patients when they present. Hearing loss, nasal polyposis, and chronic sinusitis are very common. By the time we meet these patients, they very commonly have been through many courses of various antibiotics or therapies directed against allergy. Cardiac, renal, and gastrointestinal involvement all are also very important to consider. Each of these respectively is seen in about 20% of cases. Cardiac involvement especially is one that you do not want to miss because of a significant increase in mortality risk. You want to think about screening for myocarditis and pericarditis relatively early on if you suspect EGPA. Gastrointestinal involvement can focus on the upper, lower, or both parts of the GI tract. Upper tract involvement is usually in the form of eosinophilic esophagitis. Lower tract involvement is typically an eosinophilic colitis. Eosinophilic esophagitis usually presents as a refractory reflux unresponsive to typical antacid control. The colitis usually presents with crampy abdominal pain and diarrhea. Cutaneous manifestations are also very common in EGPA. Typically, we see palpable purpura from small vessel vasculitis, chronic urticaria, and subcutaneous nodules. Nervous system involvement is especially common too with EGPA and much more so than with other systemic vasculitic entities associated with ANCA. This neurologic involvement can be motor, as we already mentioned, presenting as mononeuritis multiplex with possibly wrist or foot drop, or also can be primarily sensory or a mixed combination of motor and sensory deficits. Renal involvement can occur too in about a fifth of cases. Classically, we think of a glomerulonephritis. However, you can also develop an acute interstitial nephritis, very much like what can be seen with drug exposures such as excessive NSAID use or some antibiotics. Who gets this disease? The interesting thing about EGPA is that it affects men and women at equal rates. This is different from many other autoimmune diseases. EGPA is a disease that also often strikes a little later in life. Mean age of symptom onset is in the late 40s, and the mean age of diagnosis is in the early to mid-50s. Please note this gap, though, between symptom onset and when the diagnosis is often made. We will talk about why this gap exists a little more in a few minutes, but the existence of this gap reinforces the need for educational messaging such as today's presentation to increase awareness so that we might have the opportunity to decrease this gap. Our understanding of the pathogenesis of EGPA is complex and still poor. It is still definitely an area of ongoing active investigation. We have known, though, from as early as the original description by Schergen-Strauss that the eosinophil is a major immune player. We understand now, too, that T and B cells both, as well as a number of genetic and environmental factors, interact in complex ways to emerge as a patient-specific presentation. One of the first questions that patients with this disease often ask is, why did I get it? EGPA is an acquired autoimmune state, and it is a question of the right host being exposed to the right exposures. The right exposures, though, are still not really clear to us. There are a number of agents that have been associated with an increased risk for EGPA, including exposure to allergens, some infections, vaccinations, or new medications started shortly before symptom onset, or exposure to silica. Of course, though, there are many people who have these exposures but do not develop EGPA, indicating that exposure alone is definitely not the whole story. That is where the genetic determinants come in. There are certain Class II HLA associations identified from GWAS studies that concentrate on different polymorphisms of the DRB Class II molecule, and which also increase the risk of developing EGPA under the right environmental circumstances. Eosinophils, T cells, and B cells are all chronically activated in a dysregulated fashion in active EGPA. While eosinophils are the key effectors that directly mediate end organ damage, we now have an increasing appreciation that both Th2 and Th17 CD4 T cell subsets provide inappropriate instructions that promote eosinophil overproduction in the marrow and drive eosinophil hyperactivation in the periphery and within target tissues. Th2 T cell activity is especially irrelevant in any diagnosis with asthma as a key feature, and is characterized by the increased expression of IL-4, IL-13, and IL-5. IL-5 is perhaps the most important cytokine signal mediating these T cell instructions to eosinophils and has become a major therapeutic target, which we will talk about in the next masterclass in today's session. T cells also provide instruction to autoreactive B cells, which are responsible for producing ANCA and, interestingly, sometimes also increased output of IgG4 isotype antibodies. The significance of this increased output of IgG4 is still unclear. ANCAs, though, are thought to have a role in propagating disease by triggering and increasing the activation of granulocytes like eosinophils, especially during periods of high disease activity. Under T cell direction, eosinophils directly cause tissue and cellular damage through the release of cytotoxic, positively charged granule contents. It is these cationic granule contents that give eosinophils their characteristic red color on H&E stains, as you see in this example. Chronic exposure to these toxic contents triggers chronic or acute inflammation that, if unchecked, can become chronic and ultimately lead to fibrosis in end organs affected by the disease. We already pointed out that there is often a gap of some years between the onset of symptoms and when the diagnosis is made for many patients with EGPA. The rarity of this disease is certainly one important reason for this gap. Prevalence is estimated at least 14 cases per million, which translates to at least 5,000 or so individuals in the United States having this disease. Many of us suspect, though, that this prevalence number is an underestimate for two main reasons. The first is that physicians are not always recognizing EGPA when they see it. You cannot diagnose what you are not looking for. Second is the nature of the medications that are becoming available for asthma that are often stronger and better than previous generation drugs. Patients sometimes have GPA, but the disease phenotype can be masked for some time by strong asthma medications, and by keeping these other features at bay can make the diagnosis more difficult to recognize. We have already mentioned that EGPA is about a lot more for patients than just asthma. We cannot overemphasize enough the importance of a multidisciplinary approach to accurately diagnosing, staging, and treating the end organ features of this disease. At my institution, management is very often a collaboration between a minimum of at least 3 specialists. As a rheumatologist, I work closely with pulmonary, allergy immunology, ENT, and dermatology colleagues. And for severe cases with specific vital end organ involvement, we also work closely with our renal, cardiology, and GI colleagues. When we are thinking about EGPA for a patient, we are also often thinking about other differential diagnoses that look similar to EGPA too. EGPA, especially severe disease, is part of a specific differential of pulmonary hypereosinophilic syndromes, including acute eosinophilic pneumonia or AEP, chronic eosinophilic pneumonia or CEP, and primary hypereosinophilic syndromes or HESs. Of these diagnoses, AEP is, in many ways, the easiest to exclude because it looks the least like the other 3. These patients typically present in acute fulminant respiratory failure, get admitted to an ICU, and are diagnosed with a bronchoalveolar lavage. EGPA stands out among these entities because it is the only one associated with ANCA positivity and vasculitis. Unlike EGPA, HESs stand apart because asthma is not really a component of the typical presentation. If the patient is wheezing, this is probably not a hypereosinophilic syndrome. Finally, distinguishing a CEP from EGPA is sometimes the most challenging distinction to make in this differential. CEP tends not to have extrapulmonary manifestations, but it can. There are situations sometimes where it is difficult to distinguish early-stage ANCA-negative EGPA from CEP. The fact that we have many different diagnostic and classification criteria that have emerged over the years underscores how hard it really can be sometimes to diagnose and appreciate the full spectrum of systemic features that can be seen with EGPA. The Lanham criteria, published by Mayo Clinic investigators in 1984, are the oldest set of criteria. The reason that these criteria are not widely applied, however, is because they are the strictest of all the criteria that have been published to date. Many patients with EGPA in practice would be missed by strict adherence to the Lanham criteria. In addition to having the requisite features of asthma and peripheral eosinophilia, the Lanham criteria insist on biopsy proof of vasculitis in at least 2 different organ systems. The next criteria that came about, the ACR 1990 criteria, are much more commonly used, especially by rheumatologists. Classification requires the presence of at least 4 of the following: asthma, peripheral eosinophilia, neuropathy, fleeting pulmonary infiltrates, sinusitis, and evidence of eosinophilic infiltration on biopsy. The Chapel Hill consensus criteria, which came about next and are listed here on the far right, are also widely used by rheumatologists. The Chapel Hill definition really captures the dual histopathologic nature of EGPA. The first part of the description emphasizes that eosinophils are major pathogenic immune players, and that eosinophilic inflammation focuses on the respiratory tract. The second key histopathologic feature of EGPA, of course, is the vasculitis, which is necrotizing and focused on small and medium vessels. This definition also, for the first time, starts to reflect the association of EGPA, in some cases, with ANCA, an association that was increasingly appreciated in the 2000s. The newest and most comprehensive definition to date comes from the EGPA Consensus Task Force. These criteria expand particularly on the 1990 ACR criteria and now more accurately account for the other multi-organ features seen across the spectrum of presentation variation. At the top, you again have the requisite presence of asthma and peripheral eosinophilia. The criteria listed here on the left are carried over directly from the ACR criteria. To the right are some new features emphasizing the spectrum of more severe presentations that can be seen: cardiomyopathy, renal involvement, alveolar hemorrhage, all are now accounted for in this most current criteria. The cutaneous vasculitis and the presence of ANCA are also accounted for with the EGPA Consensus Task Force criteria. The way that pulmonologists and rheumatologists, the specialists most likely to diagnose EGPA, think about patients with this disease varies a little. For our pulmonary colleagues, patients often come because of an initial diagnosis of asthma or because of a significant worsening of known asthma that is increasingly refractory to medications that otherwise may have worked well for a long time before. For the rheumatologists, EGPA often comes to attention because of concern for a vasculitis. Pulmonologists are sometimes positioned to make a diagnosis a little earlier than rheumatologists because of the classical triphasic ordering of respiratory, followed by eosinophilic infiltrative, followed by vasculitic features with this disease. In the prodromal phase, allergic diatheses and asthma are recognized as often the earliest features and can attack patients in their 30s or 40s. The second stage is the eosinophilic infiltrative phase. This is the one that is associated with fleeting radiographically apparent pulmonary infiltrates and can also present with a myocarditis. The third and final phase of the disease is the vasculitis, the feature that often gets the attention of a rheumatologist. The vasculitic phase is classically described as the final late finding with EGPA according to the classical development scheme. These are the patients who develop mononeuritis multiplex, pulmonary hemorrhage, and glomerulonephritis. More recently, however, there has been increasing recognition that patients do not always go through all three stages in sequence. Sometimes progression of the disease will arrest in the second stage. Other times, features of all three stages can begin all at once. A key tip-off that could suggest EGPA is the presence of B-type symptoms: malaise, weight loss, fever, and diffuse myalgias. Typical lab findings encountered when patients have this diagnosis are as you see here. You need to have eosinophilia, of course, as we have said over and over. EGPA cannot be considered without evidence of peripheral blood eosinophilia. Rheumatic labs. Acute phase reactants are frequently elevated. Also, one can often see increased serum IgE levels, which correlate with eosinophilia. Rheumatoid factor and ANA are sometimes also present, but we need to emphasize that they are non-specific findings for EGPA as a diagnosis. Finally, ANCA positivity, if present, is usually of the p-ANCA type. Again, ANCA is helpful for steering you toward the diagnosis of EGPA at present and has specific prognostic significance. ANCA positivity is often a marker of classic vasculitis features such as glomerulonephritis or mononeuritis multiplex. ANCA negative patients, in contrast, tend to have a greater prominence of the non-vasculitic features such as the fleeting pulmonary infiltrates or myocarditis. Even though we talk about the importance of a biopsy for confirming the presence of a vasculitis, which is a histopathologic entity, does one absolutely need a biopsy to diagnose EGPA? In practice, we often do not have access to a biopsy at the time that we encounter a potential case of EGPA. To start with, again, you must have peripheral blood eosinophilia present to consider this diagnosis. In addition, ANCA, if present, can be used as a surrogate marker for a probable vasculitis, especially if you have a nerve conduction study consistent with the presence of a vasculitic neuropathy. Of course, asthma has to be present by definition, but the presence of asthma with some evidence of extrapulmonary end organ being involved is what really distinguishes EGPA from essential or primary asthma. Sometimes, though, even with the most exhaustive workup at the time that the patient presents, the phenotype may remain unclear, and it may take time for diagnostic clarity to be achieved as features evolve for a specific patient. If one is unsure, you have to watch closely, often for a number of months or years, and be ready to act. Let's stop here and open the floor for questions. So, one question we have, thank you. The question is bronchoalveolar lavage helpful in diagnosing EGPA, or is one better off with going directly to a lung biopsy? For this one, I'm going to turn to Mike. Mike is a pulmonologist for his thoughts.
Yeah, thank you. Really good question. The role of bronchoalveolar lavage in helping make a diagnosis in EGPA is really to, first of all, identify eosinophils in the BAL, but also to help exclude other disorders. So it can help with the exclusion of infections or malignancy or other causes of the underlying asthma. Does the patient also have vocal cord dysfunction or gastroesophageal reflux disease? So when I approach a patient for bronchoscopy and with suspected EGPA, what I'm thinking of is, first of all, do they have eosinophilia in the BAL? That can be helpful. Oftentimes, transbronchial biopsies that are done through bronchoscopy are not sufficient to give enough pathologic material to evaluate for vasculitis. For those patients in whom you are challenging the diagnosis, one should go more to an open lung or a video-assisted thoracoscopic lung biopsy. But it's a really important question to ask. I think you can also make the point when you're trying to make a diagnosis of EGPA, it's oftentimes more of a clinical diagnosis, and you don't necessarily need a biopsy in order to establish definitive vasculitis. As long as you have the other criteria, the asthma, eosinophilia with the other features, at least two of the other features that were mentioned, I think that you can make a diagnosis even without a biopsy. The purpose of the biopsy is generally to exclude other conditions.
So, we have another question. Thank you for this one. What would you advise a family practitioner to look for to avoid putting off this diagnosis? So, I think we would all agree, for those of us who see this disease, really, one has to have a high index of suspicion. We should emphasize that, yes, asthma is a feature of EGPA, but again, as we said, EGPA is about asthma plus something else being present that cannot be accounted for just by the fact that a patient clearly may have PFT proof of asthma. Really, one has to begin to suspect when you see something out of the ordinary. And it's one of the first things that one can do, of course, is with simple things. Begin with the CBC, look for evidence of peripheral blood eosinophilia. Take a good history and ask patients what else may be going on. Are there some changes in typical reflux symptoms? Is there unexplained chest discomfort? Are there also findings on labs, routine labs that suggest that there's something different about kidney function? I think that really what we must emphasize is awareness. Again, if you're not looking for something, it's difficult to diagnose it. And it's a very good question. Thank you for coming and asking. So I'll turn it over to Mike for the discussion of treatment.
Great. So the next section is entitled Individualizing Treatment for Patients with EGPA, Exploring Novel Treatment Options. So I think the first thing to remember when thinking about treatment of EGPA is, what are the goals of treatment? The key goals are to really limit disease relapse damage, to treat related morbidity, to prevent relapses, and then to reduce the toxicity of induction therapies. The key therapies that we're going to be talking about, corticosteroids, immunosuppressants, all have significant toxicity, so it's key to try to prevent those from ensuing. In terms of general management strategies, it's really going to depend on the patient presentation. How severe is the underlying disease? Does the patient have organ or life-threatening manifestations? So for patients with mild to moderate disease, you can get by generally just with use of lower dose corticosteroids. However, when patients present with organ or life-threatening manifestations, one needs to consider adding on top of glucocorticoids, some other type of immunosuppressants, such as cyclophosphamide, to help abrogate the inflammation that could be occurring in the tissue. Once you get the patient after induction therapy, you want to try to prevent long-term consequences and side effects of both the corticosteroids and other cytotoxic therapies like cyclophosphamide. And so then one should consider remission maintenance therapies, therapies that can help reduce corticosteroids, that can help minimize the risk of another relapse when a patient's on lower dose corticosteroids. These therapies include methotrexate, azathioprine, and more recently, the newly approved anti-IL-5 therapies. Now, one of the key other issues that's important to recognize, because asthma and sinus disease are so intimately involved in the pathogenesis and manifestations of these patients, it's really important to manage the patient's asthma and sinus disease. What's involved with that? Well, for those patients, you should continue bronchodilators, you should continue inhaled corticosteroids, you should definitely treat the nasal symptoms using nasal corticosteroids, and then consider other therapies for the underlying asthma. If patients warrant biologic therapies for underlying asthma, consider biologics. Anti-IL-5, anti-IL-4/13, anti-IgE have all been really important additions to the armamentarium against asthma as important biologic therapies that have been utilized. So once you treat patients and you get them into remission, you treat them, you're on a stable dose of corticosteroids, how do you monitor these patients? Well, the monitoring and follow-up of these patients is really critical so as to try to prevent further relapses, to identify relapses when they're occurring. So when you see patients, you definitely want to do laboratory measures. I generally follow eosinophil count, C-reactive protein, sedimentation rate. I want to evaluate for kidney disease, especially in ANCA-positive patients, and I'll look for drug toxicity. So I'll do urinalysis in my patients, and I'll look for any other signs and symptoms of side effects of any of the therapies that patients are on. In terms of imaging, I will generally do that on a periodic basis, depending on the organ of involvement. So if a patient is having respiratory symptoms, I'll check a chest x-ray to start with, and I might move on to a chest CT. I do pulmonary function testing in all my patients to evaluate the asthma severity and whether or not their asthma is in control. Because again, that's an important part of the management of these patients with EGPA. And then one of the key things is I want to emphasize to my patients to be vigilant for any new signs or symptoms of underlying disease. In terms of treatment strategies, we talked about the overall paradigm of getting people into remission by giving induction therapy and then giving maintenance therapy. As I mentioned, corticosteroids are the mainstay of treatment. They're the cornerstone of treatment because they effectively and quickly treat asthma and upper airway disease symptoms, and they could also stop the process of vasculitis. The problem is, however, is that corticosteroids are associated with significant toxicity. Steroids are associated with cataracts, glaucoma, neuropsychiatric manifestations, metabolic issues and fractures, growth suppression in children, increased risk of infection, adrenal insufficiency, osteoporosis, and skin-related issues. All of these are really important, and they can be bothersome to our patients and can be associated with significant morbidity and even mortality. So it's incumbent upon us to get to the lowest dose of corticosteroids possible in our patients, a dose that is sufficient to help control the disease, but one that won't result in some of the toxicity. So who can get corticosteroids alone? Do we need to give immunosuppressants to everybody? Well, it's been shown that patients with milder disease may be candidates for just steroid monotherapy. So people who have less severe disease, people who don't have kidney involvement, GI involvement, heart involvement, or CNS involvement, those patients can probably be treated with corticosteroids alone. The problem is that the disease often recurs with corticosteroid withdrawal or when you get to lower doses, and so you need to taper very, very slowly. Another issue is that few patients actually can get off of corticosteroids. And lastly, not all patients respond to corticosteroids initially. So what can you do beyond corticosteroids? What are some of the add-on therapies that you can give to your patients with EGPA? Well, several therapies have been tried in patients with EGPA. Mycophenolate, methotrexate, IVIG, azathioprine, rituximab, imatinib, anti-IgE, interferon, and cyclophosphamide. But the problem is that many of these therapies were not the result of double-blind, placebo-controlled clinical trials. And many of the reasons that we give these drugs to our patients are because of efficacy of these therapies in other disease entities, either in asthma or other vasculitides. And so we're relying just on case series for most of these. More recently, anti-IL-5 therapy with mepolizumab was approved for the management of EGPA. And this was the result, as we'll discuss, of double-blind placebo-controlled studies that demonstrated its efficacy in patients with EGPA specifically. But let's talk about some of the other therapies. What about azathioprine? Well, azathioprine has been given to patients with different vasculitides with variable effects. In one study of patients with EGPA that was just published a couple of years ago, Addition of azathioprine on top of corticosteroids for patients with non-severe vasculitis really didn't have any significant benefit. So the reflex of just adding azathioprine to our patients with EGPA may not necessarily be justified and may be associated with some side effects. In fact, in this small study, there was no decrease in treatment failures, no decrease in relapse rate, no decrease in corticosteroid use, and no improvement in asthma or sinus manifestations. What about targeting eosinophils? Well, the eosinophil possesses multiple targets and are the focus of active research. You can target interleukin-5, as I've discussed and will discuss. You could target chemokine receptors like CCR3, sialoproteins like Siglec-8, EMR1, the prostaglandin D2 receptor CRTH2, cystine-leukotriene receptors, and glucocorticoid receptors. But most of the data to date in EGPA results from investigations into interleukin-5. And that's because interleukin-5 is a cytokine that plays a role in eosinophil proliferation, eosinophil maturation, eosinophil trafficking, and survival of eosinophils. IL-5 is a eosinophil-specific cytokine. As we know, the E in EGPA is eosinophilic. And so we need to think about targeting the eosinophil as a potentially important target. These therapies have been approved for asthma, for patients with eosinophilic asthma for several years. So what are the data with regard to interleukin-5, targeting interleukin-5 with mepolizumab, which is the only therapy that's been approved for management of EGPA? Well, in the MIRA study, mepolizumab in relapsing or refractory EGPA, mepolizumab compared to placebo resulted in increased time in remission and reduced number of relapses. For instance, in patients who were given mepolizumab, there was a 50% reduction in the annualized relapse rate compared to patients who received placebo. Furthermore, one of the key outcomes in our patients with EGPA is reducing corticosteroids. Mepolizumab resulted in a significant reduction in corticosteroid dosing. As can be seen in this figure, patients treated with mepolizumab were able to reduce their corticosteroid dose from 12 milligrams a day down to about 5 milligrams a day over the course of the 52-week study. In contrast, patients who were treated with placebo only went from 11 milligrams a day and were unable to taper below 11 milligrams a day in this corticosteroid-sparing study. Now, there are other emerging anti-IL-5 therapies on the horizon. Reslizumab is another monoclonal antibody that targets interleukin-5. It's been approved for eosinophilic asthma. In a small study in 7 patients with EGPA, all with extrapulmonary involvement, after 48 weeks of treatment, all patients had a greater than 50% reduction in prednisolone dose, and there was significant reduction in terms of getting down to below 7.5 milligrams per day. This was an open-label study, and there are more studies that are currently in development really looking at reslizumab as well. With regard to benralizumab, a novel monoclonal antibody that targets the IL-5 receptor, benralizumab has been shown to be effective in patients with eosinophilic asthma, and in a small pilot study, benralizumab demonstrated significant efficacy in 10 patients treated with EGPA, resulting in reduction in exacerbations as well as in corticosteroid dosing. In fact, benralizumab was granted FDA drug orphan status for EGPA in 2018 and is currently the subject of a double-blind, placebo-controlled study comparing benralizumab to mepolizumab. Other drugs that are currently considered for patients in EGPA include omalizumab, which is an anti-IgE monoclonal antibody that's been approved for allergic asthma, rituximab, which has been shown to be effective in patients with vasculitis, dexpamiprexol, which is an investigational agent which has been shown to reduce eosinophils, and anti-Siglec-8, which is again another experimental therapy. So, getting back to the basics about EGPA, in summary, it's important to recognize the signs of EGPA, take note of the high eosinophil counts, do a substantial lab workup, and collaborate with your colleagues in the treatment and long-term follow-up of patients with EGPA. If you don't have expertise, refer your patients to physicians who do have expertise in EGPA. And although EGPA has significant morbidity, prognosis has greatly improved over the last several decades. We're understanding this disease better, we have novel therapies for this disease entity, and we're doing a better job managing our patients. This progress in our understanding of EGPA has also now provided new therapies and emerging therapies that I think will help us for years to come. While corticosteroids are first-line therapy for our patients, they do have significant side effects. So we need to think about what else can we do for our patients with EGPA and consider biologics or other cytotoxic therapies, other immunosuppressants, particularly for patients who have steroid refractory disease, patients who require step-down therapy and can't taper down their doses of corticosteroids, and patients who continue to relapse. And as newer therapies emerge and advances in EGPA continue, clinicians will actually have more tools to better diagnose, treat, and care for our patients with EGPA. So let's move on now and let's do another quick case presentation.
So, thank you, Mike. We have for this case a 56-year-old Caucasian male with a 30-year history of asthma. His history otherwise is significant for comorbidities of hypertension, hyperlipidemia, and a history of COPD secondary to paint exposure that was in the setting of his previous occupation. He notes that 8 months earlier, as he was trying to clean dusty shelves at his place of employment, that he needed to visit a walk-in clinic, after which his asthma attacks began occurring on a regular basis. His asthma attacks were treated with prednisone, but when the prednisone was tapered, the asthma came back. Let's take a moment here and discuss what we've seen so far. Mike, what do you think when you hear this story? Is there anything here that would raise suspicion for something like EGPA?
Well, any patient that I see who has frequent asthma attacks, frequent courses of prednisone that get better and then get worse, I'm starting to think about, well, what type of asthma does this patient have? And could this patient have some other process that's ongoing? He's got a long history of asthma, but it was adult onset asthma. It only started when he was 26. That's associated with underlying eosinophilic diseases. It's unclear exactly why he developed the asthma. Clear there's some environmental component, but when I see patients who've got adult onset asthma, who have frequent exacerbations, I start thinking, could this patient have eosinophilia? Could this patient have some other process like EGPA? So just with the frequency of exacerbations, my wheels are turning and I'm starting to think, could this be EGPA?
A little more history. 8 months after his asthma attacks began occurring with regularity, the patient developed emesis and a high fever, which he treated symptomatically with PRN loperamide and Tylenol. In the same month, he was hospitalized for pneumonia and a new lower extremity rash in the setting of eosinophilia and leukocytosis. He received antibiotic treatment. His lower extremity exanthem was believed to be due to an insect bite or a drug exposure. Later that month, he was again hospitalized for sudden onset pain in the left lower extremity that he described as shooting, burning, and throbbing in character. So, Mike, what do you think now as you hear this story continuing to evolve? Definitely more than just his asthma, right?
Yeah. So something else is going on, and it's really incumbent upon us to try to figure out what else is going on. The key features for me are the eosinophilia, the pulmonary infiltrates, and the rash. He has had fevers, he's had some GI complaints, and he's also had the left lower extremity pain. But for me, why does the patient have eosinophilia? So you need to think broadly. What's in the differential diagnosis of eosinophilia? First, you need to exclude drug reactions, the most common thing in the United States. Or you need to think about what else could be causing eosinophilia. The most common thing worldwide are parasitic infections and other infections. Could the patient have malignancy? So the wheels need to start turning. But in the presence of asthma, adult onset asthma in particular, eosinophilia, pulmonary infiltrates, you need to start thinking, well, why does this person have a rash? You need to take a good history. You need to think about doing a biopsy. And you need to do really more of a workup. I would already start thinking about EGPA in this patient. You could also say, could the patient have hypereosinophilic syndrome? What else could be going on? It seems a little bit too coincidental, this long history of asthma and eosinophilia. We mix with all these systemic manifestations. So I would automatically start thinking that this is probably a case of EGPA.
I definitely agree with that. For sure, he has evidence of some multi-organ involvement already. You begin to see this pain in the lower extremity, suspicious for a neuropathy, the peripheral eosinophilia, the cutaneous findings. Again, we can't overemphasize enough that one of the keys to closing the gap that we already mentioned for when a patient presents with EGPA symptoms and is ultimately diagnosed, that gap of a number of years, it's really a matter of physician awareness and being able to suspect when you see asthma with other features that it's not just asthma with other features. So this gentleman, his presentation continued to evolve even further. He had rash on his legs, hives on his face, and purpura on his lower extremities that developed all pretty fulminantly within 2 days of his rehospitalization. As part of the workup for his neuropathic pain, an MRI was obtained that demonstrated degenerative disc disease at L4 to 5 and L5 to S1, with a mild broad disc protrusion at L5 to S1 and a mild mass effect on the thecal sac. The neurologic consultants who evaluated him commented in their assessment that it was difficult to distinguish vasculitis from nerve impingement, and outpatient follow-up is recommended. I would just say that this is a scenario that we sometimes see with the onset of neuropathic symptoms. Sometimes it can be difficult to distinguish acutely vasculitic neuropathy from other types of neuropathy. And it may require that ultimately, as the features evolve, that one may have to repeat the nerve conduction study to get a clearer picture. It should also be noted that there is a component of interoperator variability and some variability sometimes in the interpretation of a nerve conduction study. And sometimes, it's important to have your antenna up and to go with what you know and to go with the gut suspicion that there may be something else here at play that is unifying. And so the patient also, in addition to being seen by neurology, his rash that we mentioned, this is a picture of his findings, certainly looks on first appearance consistent with the typical palpable petechiae purpura image that you would expect for a leukocytoclastic vasculitis. The patient was empirically initiated on prednisone for a week, and which was followed by a instruction for a taper. So despite this, though, the patient continued to have pain in the left lower extremity and difficulty ambulating. He had ankle brachial indices to try to see if there was a claudication component to his symptoms, and the results of the ABIs are as you see here. The original rash seemed to improve with the empiric steroids, but was not completely resolved. His notable test results from this admission are as you see here on the right. Mike, what do you think now as you see this picture continue to evolve?
Yeah. So, the combination of the clinical findings, certainly of the rash, the pulmonary infiltrates in the context of asthma, as well as the other systemic manifestations, raise the specter of EGPA. But it's really this high eosinophil count that's observed, 26% plus eosinophils, absolute eosinophil count of almost 4,000. With negative workup for other entities, negative hepatitis A, B, and C, the small vessel vasculitis that's observed on a skin biopsy. The fact that he's ANCA negative doesn't sway me one way or the other. If it's positive, it's helpful in terms of the diagnosis of vasculitis, but only 30 to 40% of patients are really positive for anti-neutrophil cytoplasmic antibodies. So that doesn't say, oh no, this isn't EGPA. The high IgE that can be present, the high C-reactive protein sedimentation rate, and rheumatoid factor all really can result in occur in patients with EGPA. So to me, given the multitude of findings, this seems to me to be a diagnosis of EGPA. Let's hear what happened. How did they treat him? What happened in terms of diagnosis?
I agree, Mike. Just one thing I would add. You'll recall that earlier we said that ANCA sometimes, if present, is used as a surrogate for pointing you towards vasculitis. Again, as Mike said, and as I have said earlier, though, ANCA is only present in a little under half of cases. This is a patient here that you can see had biopsy proof of the vasculitis and yet was ANCA negative. And again, to reiterate, as Mike has said and as I have said, the presence or absence of ANCA, while helpful if present, definitely is not calling for or against probable EGPA. In terms of treatment, so the patient, because of this pretty stormy picture of multi-organ involvement, was induced up front with high intensity immunosuppression together with his continued steroids. He received oral cyclophosphamide at a dose of 2 milligrams per kilogram, and then the prednisone was bumped up to 1 milligram per kilogram followed by taper. Yet, as the prednisone was tapered, his asthma gradually came back and was refractory to inhalers. Consequently, thereafter, the decision was made to add mepolizumab at 300 milligrams given once for a month. And then 3 months later, he was doing much better, completely off of steroids and maintained on azathioprine on mepolizumab. However, his foot drop remained, though it was stabilized without evidence of progression. And his neuropathy had not progressed to involve any of his other extremities. So Mike, as you look at this, any thoughts on his treatment, the appropriateness of the intensity of agents that was selected, the sequence in which it was selected? Any thoughts on the amount of prednisone that was given with the cyclophosphamide?
Yeah, sometimes you have to give a substantial amount of corticosteroids and cytotoxic therapies to get the patient under control. And in this case, he clearly wasn't under control, and he required the higher doses of steroids and cyclophosphamide to get the patient into control so that he could then undergo some remission, potentially disease-modifying therapy in the form of the mepolizumab and azathioprine. The fact that he continued to have foot drop doesn't tell me that he wasn't responsive. It really reflects the probability that just damage was done, and it's going to take some time for that damage to heal, if at all. But it really gets back to the point that we need to treat this disease aggressively to try to prevent the damage, because the damage can happen in the nervous system. It can also happen in the cardiac system. You don't want patients developing cardiomyopathy. And so, again, the key thing is to make a diagnosis early on, treat early on. Don't wait for a biopsy necessarily to come back. You can treat empirically with corticosteroids if you think it is definitively vasculitis or a manifestation of EGPA.
Thank you,
So
Mike.
it looks like we have a couple of questions. I'll take some time for some questions as well. First question is what's the role of ANCA in monitoring of EGPA progression? Well, anti-neutrophil cytoplasmic antibodies can play an important role in patients with EGPA, but as we mentioned, not all patients with EGPA have ANCA positivity. Interestingly, patients can become ANCA positive, or if they're ANCA positive, they can become ANCA negative. There were some studies from the Mayo Clinic over the last couple of decades that suggested that perhaps ANCA positivity could wax and wane with disease activity. That hasn't been corroborated at all. Do you want to sort of review one? I think we've got some more questions here. Do you want to take a quick crack at another question?
So before we do, I just want to add to what Mike said about ANCAs. In practice for us, Mike is exactly right. There is really not been subsequent data that shows that ANCA correlates with disease activity. And as a matter of fact, in our center and in many other centers, we simply ask, is ANCA present or not at some point in the patient's presentation? and otherwise we really do not routinely check it. So another question. So let's see. Oh yes, here's a question. Thank you. How do we manage pregnancy in patients with EGPA? So this definitely is always a challenge, not just with EGPA, but many of the diseases that we share with pulmonary. Of course, this certainly means that cytotoxic therapies like Cytoxan are out. Also, other agents like CellCept, methotrexate definitely are taken off the table. We are often forced to rely more so on steroids. And then there are also other steroid-sparing agents such as azathioprine, and then also even rituximab, for which there is no data indicating that they should necessarily be contraindicated with pregnancy. But even with mepolizumab, regardless, this is a discussion that we really have in detail with patients when pregnancy becomes apparent. And what I always do is I just have a deep discussion with people. I'm honest with them about what we know and what we do not know. And it's something that each individual pregnancy is different. Each person's EGPA is different, and we work through it together. For you, Mike, how do you approach this?
Yeah, I think it's balancing the risks and the benefits. You really want to take care of the mother, and if you take care of the mother, then you'll be taking care of the fetus. That being said, there are unknown risks for some of these therapies, including mepolizumab, and so I think one needs to approach this subject with caution and involve as well the patient's OB specialist in order to help the patient make an informed decision. Another question that came up, a couple of questions actually along the same theme are, assuming an anti-IL-5 agent is used in disease, how long does the patient need to get treatment? Another question that's related is, how long does one need to treat this condition? Is it lifelong? I think it's really important that the goals of management, again, are really to get patients into remission and to prevent relapses. So it really is going to depend on how long you follow the patient and what the goals of care are. Generally, my goal is to try to get patients down to a low dose of steroids as possible. Ideally, I'd love to get my patients off of corticosteroids. In the MIRA study, in fact, 19% of patients were able to come off of corticosteroids while they were on mepolizumab therapy. In terms of the long-term management, what are my goals? Well, again, it's the same types of goals, including getting people off of other therapies. Do people need to have lifelong treatment? We don't quite know that as of yet. It hasn't been shown that these therapies are disease modifying in any way. Certainly in my experience, some patients have been able to come off of all therapies and do fine, but some patients that have taken off of either their anti-IL-5 therapy or their corticosteroid therapy or their other immunosuppressants may experience relapses, and then many of those patients decide that they want to go back on therapy. It's really a balance, and I think you need to evaluate the risks and benefits of all these different therapies. What are your thoughts?
So I agree, Mike. That being said, I think one has to remember that mepolizumab, right, and some of these other agents are pretty new. And so there really hasn't been time to conduct the long-term follow-up that we would need to more objectively answer these questions. Is it true that there are some patients who are successful in coming off of therapy and maintaining disease-free remission? Definitely. In our own practice, we see that from time to time, and as Mike said in his practice as well. But it would be ideally preferred if we could one day have, clear guidance on predicting who these individuals might be up front. In the meantime, it really remains a very individualized discussion of risks versus benefits in terms of when and how to attempt to reduce therapy or withdraw. So
thank you so much, and have a great day.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerview.com /GKC860.